All right, continuing our discussion with diabetes. So, as always, I like to start with a big picture of what are we doing exactly. And I really like this slide because it brings down all of the medications in diabetes into one slide. So as we know, the problem with diabetes is hyperglycemia. In type 1, there's no insulin. In type 2, there's not enough insulin, or if there is, the cells are not responding to it. So if you think of it, of how can we fix this problem? So first thing that we can do is, we can replace the insulin. So there's different forms of insulin. There's um, ac- according to the onset of action and the duration of action. So we can give insulins. We can also decrease glucagon and decrease gastric emptying because, as we know, in diabetes, there is high amounts of glucagon, and these are achieved by medications called the incretins and amylins. And these medications are these are actually hormones that are naturally occurring in our bodies, and we've developed analogs for it. So the incretin analogs example is exenatide, and then amylin analogs example is pramlintide. And these medications decrease the glucagon and decrease gastric emptying. Um, now, these uh, hormones, the incretins, are present in our body, and they're actually broken down. And we've identified how they're broken down. So they're broken down by an enzyme called DDP4. So we can inhibit the breakdown of these incretins by DDP4 inhibitors, like medications called sitagliptin. Next is that we can stimulate glucose uptake and inhibit liver gluconeogenesis, so making of new glucose by metformin. We can increase insulin release by medications called secretagogues. So secrete, they increase the secretion of insulin. So the two examples of medications that increase the insulin secretion are sulfonylureas. An example of that is glipizide, and then the other example is meglitinides. And the classic for it is repaglinide. So sulfonylureas and meglitinides, they increase the insulin release. We can inhibit glucose absorption from the intestine. An example of that is alpha glucosidase inhibitors like acarbose. Or we can inhibit the glucose reabsorption from the kidney. So, for example, is using the sodium glucose uh, transporter 2 inhibitors like canagliflozin. So that inhibits the glucose reabsorption from the kidney. And then finally, we can synthesize the cells to insulin effects using class of medications called thiazolidinediones. And the example of that is glitazone. So in essence, what we're doing is we're either replacing insulin, we're increasing insulin release, or we're synthesizing the body to the insulin response. So what I want you to do is I want you to go over this and kind of burn it down in your brain, because if you understand this, then the rest of diabetes will actually be very easy. So the first thing that we're going to talk about is insulin, and insulin just provides replacement uh, for the endogenous insulin that we have. How it works, and it's actually pretty important to understand what kind of receptor it is. So it binds to the insulin receptor, which is a tyrosine kinase receptor, and it causes its phosphorylation. The physiology of insulin is that really there is basal insulin. That means that there's insulin that's continuously secreted from your pancreas. And then there is also postprandial insulin that is secreted in response to the glucose surge that happens postprandially. The goal of replacement of insulin is to mimic the physiological response, to give something basal and to give something postprandial. Insulin is classified according to the onset of action and the duration. So there's really four classes of insulin. There's the rapid acting that works right away, 5 to 15 minutes, and lasts about 2 to 4 hours. The short acting takes about half an hour to an hour to work and lasts 3 to 6 hours. The intermediate takes 2 to 4 hours to work and lasts about 10 to 12 hours, so half of the day. And long acting takes about 1 to 2 hours to work and lasts 12 to 24 hours. I don't want you to get caught up on the exact numbers, but I want you to understand that there's different different forms of insulin according to the onset and the duration. Before I get into the specific types of insulin, I want to touch about the side effects of the insulin. First thing, of course, it can cause hypoglycemia, and it can cause weight gain as well. Um, Insulin can also cause changes in the fat distribution, so it can cause lipohypertrophy. So you can have like a lot of fat in one place, or lipoatrophy, that you can have decreased fat in one place of the body. Also, insulin causes hypokalemia, and we'll go over the mechanism of why insulin causes hypokalemia. So starting with the different types of insulin, the first one is the rapid acting, and that comes in the flavor of aspart, lispro, and glulisine. And it's important to know these names, especially the aspart and the lispro. It's a subcutaneous injection, and it's used for prandial coverage for type 1 and type 2 diabetes, and also for gestational diabetes. Why is it used for prandial coverage? Because it's rapid acting. It works right away. Patient inject it as soon as they start eating, or a little bit before they start eating, and it works right away. So it provides good prandial coverage. The short acting is the regular insulin. The regular insulin meaning the insulin that is not modified. All of these insulins, the aspart, the lispro, and glulisine, these are modified. They either add amino acids or add two amino acids, and they make these fancy names. The short acting insulin, this is insulin that is very similar to the endogenous insulin that we have. This regular insulin can be used subcutaneously or through the IV. This is a very, very, very important point to understand. This is the only insulin that comes in IV form, and that will come important in a second. It's used the subcutaneous form. It's used for prandial coverage for diabetes, type 1, type 2, or gestational. Not as much, because it takes some time to act. If you look here in this chart, it takes about 30 to 60 minutes to act. So that's not as ideal for patients. Patients want to inject and use right away. But really, the biggest use for regular insulin is the IV form. The IV form can be used in two things. The first thing is that the IV form can be used in diabetic ketoacidosis. Can you tell me why can the IV form be used for DKA and not any other form? So I'll tell you, because in DKA you want to have the insulin get into the bloodstream right away. If you inject the subcutaneous, either rapid acting or intermediate or long acting, they're not going to get into the bloodstream right away, and they're certainly not going to act right away. So you can use the regular insulin for diabetic ketoacidosis. The second use for it is for patients that have hyperkalemia. And this is a very, very, very important point to understand how insulin acts to decrease the serum potassium. So insulin stimulates the sodium potassium ATPase pump. And if you remember from physiology, the sodium potassium ATPase pump pushes brings potassium into the cell and kicks sodium out of the cell. So it causes hypokalemia. So in patients that have high serum potassium for whatever reason, you can give them insulin and it stimulates that sodium potassium ATPase pump. It's thought that it stimulates it by providing more ATP from the metabolism of glucose. However, the point is that it stimulates that pump and it treats hyperkalemia. This is a short-term use, um, short-term treatment for hyperkalemia. We're going to talk about hyperkalemia later, but the point is that you can use short-acting or regular insulin through the IV form for DKA and for hyperkalemia. Very, very important for STEP and actually for clinical rotations. Third type of insulin is the intermediate acting, which is insulin NPH. It's used subcutaneously and it provides basal coverage, which means the long kind of consistent coverage for insulin. And finally, the long acting, which is detamir and glargine, also subcutaneous and provides basal coverage. So it's given once or twice a day. So really highlights is this is for use after meals. This is for used for DKA and hyperkalemia. These two are used as basal coverage. So that's for the insulin. Now, our next class of medications are the incretin and amylin analogs. So let's talk first about the incretin hormone. So the incretin hormones are released from the beta cells of the pancreas in response to the oral glucose, not the IV glucose. So oral glucose goes in the stomach, stimulates these hormones to be secreted from the beta cells. So these hormones increase insulin release. They slow gastric emptying and they inhibit glucagon release and they increase satiety. They kind of tell the body, hey, I've had enough food, kind of slow down on, on feeding me. I've had enough and I'm gonna, digest all of this food first. And these hormones come in two flavors. And the first one is glucagon-like peptide, GLP-1, and then the other one is gastric inhibitory peptide. And as the names imply, these are things that kind of um, inhibit uh, gastric or slow gastric emptying. These hormones are degraded by dipeptidyl peptidase 4. So this is a protein or an enzyme that degrades these hormones. So what scientists have made use is that they've um, made a hormone that's very similar to these incretins called exenatide. So exenatide actually came originally from the lizard spits. Fun fact about exenatide. It's used as an adjunct, meaning in addition to other things in type 2 diabetes. It's used for weight loss and type 2 diabetes as well, because remember, it increases satiety. So that's a big thing for patients that want to lose weight. Side effect, which is actually very high yield for exenatide, is that it causes pancreatitis, and the mechanism is not really clear, but is thought to cause acinar cell hypertrophy, and it causes a lot of inflammation and eventually pancreatitis. So exenatide causes that. It doesn't really cause hypoglycemia. So exenatide has low risk for hypoglycemia. Next medication that we're going to talk about is pramlintide. Pramlintide is an amylin analog. So let's talk a little bit about amylin. So we talked about the incretins. Amylin is a similar hormone. It's secreted with insulin from the beta cells. So remember, incretin is not really secreted with insulin. It's secreted in response to oral glucose, but amylin is secreted with insulin. But it has similar actions. So it slows gastric emptying, it decreases glucagon release, and it acts to control postprandial glucose. So the analog for amylin is pramlintide. It's used as an adjunct in type 1 and type 2 diabetes. It's subcutaneous only. Side effects for it is gastroparesis because it slows gastric emptying. Exenatide can also cause gastroparesis, and amylin cause hypoglycemia and weight loss. But really, the biggest thing that I want you to know is that these medications are analog of incretin and amylins, and the one really big side effect is the pancreatitis from exenatide. So these are the injectables. We talked about the insulin and we talked about the amylin and the incretin analogs. Now we start getting into the oral agents. So the first oral agents, and really the oldest one that we know, is metformin. And metformin, how it works is that it activates a protein called 5-AMP protein kinase. So AMP protein kinase is a kinase that responds to increased stress and energy demands. That protein stimulates peripheral glucose uptake, inhibits liver gluconeogenesis, and the biggest thing is that increases insulin sensitivity. And that's why we really use metformin. It doesn't cause hypoglycemia. So metformin is pretty much used everywhere. It's even used in type 1 diabetics. I didn't put it here, but it's used for pre-diabetics, um, it's used as a first line in type 2 diabetes. It's used for weight loss in type 2 diabetes, and it's also used in type 1 diabetes as well. Interestingly enough, it has been used in polycystic ovary syndrome because, as you know, in PCOS, you have insulin resistance, and that contributes to the pathology of PCOS. So metformin acts to counteract the insulin resistance. Side effect for metformin, first thing is that you can actually have modest weight loss, which is something that's beneficial for some of the diabetics. The biggest two things that I want you to be aware of for metformin as far as side effects is that there have been rare cases of lactic acidosis in patients with renal failure. And the reason for that is metformin inhibits some of the mitochondrial enzymes, so the mitochondria is not able to process the lactic acid, so you have some cases of lactic acidosis. So you want to avoid um, metformin in patients with renal failure because metformin is um, excreted by the kidney, and if the kidney can't excrete it, then it's going to accumulate and you have higher chance of lactic acidosis. So that's the first thing that I want you guys to be aware of. The second thing is that metformin can cause significant diarrhea to the extent that patients actually stop taking it. But the good news is that the diarrhea actually um, kind of stops on its own with the continued use of metformin. So these are two things that test examiners can test you on: lactic acidosis and diarrhea with metformin. Next, agents are the sulfonylureas. So sulfonylureas come in two generations. The first generation is sorry, clopropramide. And the second generation, you have glipizide, glyburide, and glimepiride. How these medications work in a nutshell is that they increase insulin release. Now, that is not enough to understand. You have to understand how it increases insulin release. So, what they do is that they close this channel, the ATP sensitive potassium channel. So, when they close this channel, they decrease potassium conductance. So, more potassium stays inside of the cell is depolarized. When the cell is depolarized, it leads to opening some calcium channels. When calcium is opened, you have a lot of intracellular calcium, and that causes fusion of insulin granules with the cell membrane, so it causes more insulin to be released. Now, the trick for that is that you actually need a functioning pancreas or functioning beta cell for the sulfonylureas to work. So the sulfonylureas, they're used for early stages type 2 diabetes in addition to metformin. As I've said, you need some islet cell function. So it doesn't really work in type 1 diabetes because there is no really islet cell function left, or late type 2 diabetes because you've burnt out all of your islet cell function. Side effects is that it can cause pretty profound hypoglycemia if the meals have been missed. So if patients take their medications but they don't eat, it can cause us some weight gain. And one of the things that sometimes come on exam is that specifically with the first generation sulfonylureas, specifically clopromide, you can get disulfiram reaction with clopromide. So that's something to be aware of. Next agents that we're going to talk about is actually I'm going to talk about the meglitinides first. The classic is repaglinide, and repaglinide works in a similar way to the sulfonylureas that we have just talked about. So it decreases potassium conductance and stimulates insulin release. It works in a different site than the sulfonylureas, but it's the same idea. It's used as a monotherapy or adjunct in type 2 diabetes, specifically to control postprandial hyperglycemia. So the test question will ask you, I have a patient who has normal fasting glucose, but very high postprandial. What medication can you use? And the answers will be, um, and it would be like a type 2 diabetic. The answer will be a lot of other things. Among them is repaglinide. And that would be kind of the place to use it to control postprandial hyperglycemia. Side effects is it causes hypoglycemia and it doesn't really affect the weight. Next class of medications are the alpha glucosidase inhibitors. So the classic medications is acarbose and miglitol. The one that I would really focus on is the acarbose because that's the one that tends to show on exams. But really, it's important to understand the idea. So these medications inhibit the brush border alpha glucosidase enzyme in the small intestine. So this enzyme breaks down starch and disaccharides to glucose. So if you're not able to break down the starch and the disaccharides, you're not going to be able to absorb glucose in your small intestine. So these medications decrease postprandial hyperglycemia as well. And it's used as an adjunct in type 2 diabetes. They're weight neutral, they don't really cause hypoglycemia. Administration is very important for these enzymes. And the counseling point is that we advise patient to take with the first bite of meal because that's when it works the best. Side effects, it causes GI disturbance and it causes liver toxicity. The classic test question about these enzymes is about these medications is asking you where they work. And it works on the brush border of the small intestine. So that's the highlight of this class of medication. Next class of medications are the thiazolidine diones, and the suffix for it is glitazone. So pioglitazone and rosiglitazone are medications in this class. And how these medications work is that really they're insulin sensitizers, so they increase the insulin sensitivity in the tissue. How they do that is that they activate a nuclear transcription factor called PPAR gamma, and that somehow increases the insulin sensitivity. The mechanism is not very clear, but that's the idea. It's used as an adjunct in type 2 diabetes. The one thing that I want you to be aware of these medications is that they're cardiac risk factors. So they have a risk for myocardial infarction, and they're also contraindicated in congestive heart failure, and there's a black box warning. So that's the one thing that test examiners can test you on it. They'll ask you, for example, I have a patient who is on a medication that activates PPAR gamma. What would be the major contraindication for this medication? And the answer would be either MI, previous history of MI, or history of CHF. So that's the thiazolidine diones, the glitazones. Next medications are the DGP4 inhibitors, and the suffix for it is the gliptins. So example is sitagliptin and saxagliptin, and these are oral medications. As I've talked about earlier, these inhibits the dipeptidyl peptidase 4 enzyme. So if you guys remember, we talked about the incretins, the endogenous incretins, the GLP-1 and the GIP. These are the medications, these are the hormones that decrease gastric emptying and improve satiety, um, but they're broken down by this enzyme, the DGP4. So what you can do is that you can inhibit that enzyme and you'll have a longer half-life of these endogenous incretins. They're used as an adjunct in type 2 diabetes. Side effect for it is the biggest thing is really pancreatitis. And if you remember, the exenatide, which is the incretin analog, causes pancreatitis as well. These medications are weight neutral and they have low risk for hypoglycemia. The last oral hypoglycemic that I'm going to talk about is the SGLT2 inhibitor, which is sodium glucose transporter 2 inhibitor. And the medication in that class is called canagliflozin. And how it works is that it blocks the glucose reabsorption in the proximal convoluted tubule. So what happens is that it goes and blocks this transporter so that you have more glucose that's being spilled in the urine and you're not able to reabsorb it. As you know that we reabsorb nearly 100% of the glucose that we filter through the kidney, but this medication blocks that process. It's used as an adjunct in type 2 diabetes. Side effects for it, as you can understand from the mechanism, that it spills glucose in the urine, so you'll have glucoseuria, which is, a known effect of the medication. You'll also get UTIs from these medications, and it can be easy to understand because if you have a lot of glucose hanging out in your urine or urinary tract, the bacteria is going to feed on it. You'll also get dehydration and polydipsia because glucose is an osmotic diuretic. So glucose will stay in the urine and it will pull water to it. So you'll get dehydration and polydipsia. So that's the canagliflozin, which is an SGLT2 inhibitor. So all of these things that we talked about are the hypoglycemic agents. These are medications that cause hypoglycemia in response to high blood sugar. Now, what if you have low blood sugar? What are you going to do? So you're going to ask yourself, well, why do I have low blood sugar? And it can be one of two things. The first thing that can cause low blood sugar is a tumor in your beta cells of the pancreas, namely insulinoma. So if you have a tumor that keeps secreting insulin, you're going to have low blood sugar. The other thing that can happen is that you can have an overdose from either sulfonylureas or insulin. These are the biggest two things that can cause an overdose, and that will cause hypoglycemia. So the response to that is that what do I do? So the first, so we need, of course, to raise the blood sugar. Well, how are we going to do that? The first thing that we're going to do, of course, is that we're going to give glucose. And the second thing is that we're going to determine the cause of the low blood sugar. So if the cause is insulinoma, we can use a medication called diazoxide. So diazoxide, it's used for insulinoma, and it's pretty much the opposite mechanism of action of sulfonylureas. So it increases the open time of the potassium channel, which inhibits insulin release. So this is blocking insulin from being released. Again, it's used for insulinoma, and side effect just sodium and water retention. So that's one cause of low blood sugar, insulinoma. Second cause of low blood sugar is that if you have an overdose um, on um, on um, insulin or sulfonylureas, then you can give glucose, you can give glucagon. So that brings up to our next point, which is glucagon. So glucagon, as you know, is an endogenous hormone, but we have developed a synthetic version of it. How it works is that it increases cyclic AMP and IP3 um, through the intracellular pathway and increasing calcium release. It's used for hypoglycemia. It's also used for beta blocker overdose, and this is a very, very important toxicology point. The reason for that is beta blocker decrease cyclic AMP and calcium. So glucagon opposes that effect. So you can give glucagon if you have a patient that has a beta blocker overdose. Also increases contractility. The last thing that glucagon is used for is that um, you have it confirms the diagnosis of pheochromocytoma because it causes release of catecholamines from the adrenal medulla. Side effects of glucagon is you can get vomiting after giving the dose. So that's as far as hyperglycemic agents, agents that cause hyperglycemia. Now, I wanted to just take one point to talk about an algorithm for hypoglycemia because I think it's not very well addressed and may not be very well understood. If you have a patient with low blood sugar, first, before anything, you need to treat the low blood sugar. After you treat the low blood sugar, you need to figure out the cause. Now, how are you going to treat the low blood sugar? So if you have an asymptomatic low blood sugar, meaning the mental status is normal, you can give the patient oral glucose. So they can tolerate it. You can give them some orange juice, you can give them some glucose pill, whatever it is. If the patient is altered, then they're not able to swallow, or if they'll aspirate on the oral glucose that you give them, then you need to give them something parenterally, which means either through the IV or intramuscularly. If patient has IV access, that means if they're in the hospital, they have an IV line, then you give them IV glucose. If the patient does not have IV access, then you can give them an intramuscular injection of glucagon. You can't give them glucose intramuscularly because the volume of glucose is so big, and you wouldn't be able to give all of this intramuscularly. So you'll give IM glucagon. If patients have insulinoma, then you can use diazoxide. So I hope this algorithm makes sense to you. Now, I wanted to talk a little bit about the summary of diabetes and treatment. For diabetes 1, there's different strategies. The main point is that you're giving two things, a basal insulin and the fast-acting insulin. So strategy 1, you can give basal insulin like glargine or detamir, and you combine it with fast-acting with meals like aspart or regular. Strategy 2 is that you can give an intermediate acting like the NPH with some fast acting combined in the same injection, and that's given twice a day. And the third strategy is that you can give an insulin pump that delivers basal and boluses with the meals, and that can be filled with aspart, insulin aspart, or regular insulin. For type 2 diabetes, there is some various guidelines, and it really depends on the A1C and patient-specific characteristics. The first step for type 2 diabetes is lifestyle. Um, After lifestyle, you can add metformin, and then step 2 is that you can really add any of these. For both type 1 and type 2 diabetes, just a few important points that may show up on exams. If you have a patient that's acutely hospitalized, if you have a patient that's diabetic on, oral medications for diabetes, and they're hospitalized, you stop the oral agents and you put them on sliding scale insulin, meaning that you give them insulin according to the sugar. And the reason for that is because in the hospital, patients are not eating, they may be going for tests, their blood sugar is fluctuating, so you don't want to give them something oral that will last for a long time, but you give them something that's short acting. When for patients that are diabetic, they most of them have dyslipidemia, so you give them a statin, and you also give them an ACE inhibitor or an ARB to prevent diabetic nephropathy. So that these are important things to understand, and these are easy points on the exam. Which brings me to my last point, which is the treatment of hyperkalemia. I know this is kind of is out of place and it doesn't really fit anywhere, but because we have talked about insulin, I felt that it was important to address the treatment of hyperkalemia because we don't really talk about it anywhere. The first thing is that you need to treat this hyperkalemia because hyperkalemia can stop the cardiac activity and leads to ventricular tachycardia, ventricular fibrillation, eventually asystole. So short term, you can do a few things that work pretty quickly. You can give IV insulin plus dextrose, and we talked about the mechanism because it pushes the potassium inside the cell using the sodium potassium ATPase pump. Second thing is that you can use sodium bicarbonate, which if patients are acidotic, it corrects the acidosis and exchanges the extracellular potassium for intracellular acid. So it pushes the potassium inside of the cell and brings the acid outside of the cell, which gets neutralized by the sodium bicarbonate. Third thing that we can do is that we can give albuterol, which is if you remember, it's a beta 2 agonist used for asthma, but it's an adrenergic agonist because it works on the sodium potassium ATPase pump and it stimulates it as well. And the last thing that we can do is that we can give IV calcium. And IV calcium doesn't really do anything with the potassium in general, but it stabilizes the cardiac membrane and it prevents arrhythmia. And we really only give calcium if there is any EKG changes, so mainly peaked T wave, because that's the highlight of hyperkalemia. So these are the short-term treatments for hyperkalemia: insulin, sodium bicarbonate, albuterol, and calcium. Now there are some things that we can do to remove potassium from the body, and these are intermediate term. So the one medication that we can use is a medication called sodium polystyrene, and it's an oral medication and it's a chelator. That means it binds to the potassium, and where it binds, it actually binds in the colon, and it increases secretion of potassium. So that's one medication that we can use. And then the other medication is furosemide IV, and that increases the renal excretion of potassium. Lastly, we need to fix the cause long term, so we can use that. We can do dialysis if patients are in renal failure, or we need to fix the underlying cause of why the patient is hyperkalemic. So that is really the treatment of hyperkalemia. I hope this review session was helpful. There are a few questions that are after the slides. I just wanted to encourage you guys, and I know that this is a period of time where you're pretty much in the middle of the road. I think of step one as kind of climbing a mountain, and you're like in the middle right now. You've started, but you've reached the middle and you're kind of starting to get bored, tired, but keep pushing because the end is near. I was recently in the Smoky Mountains, and I climbed one of the mountains. In the middle, it started to get really tough, but once I got to the end, it was really worth it. So keep pushing, guys. Take breaks, take care of yourself, and it'll be over soon. With that, I'll end. If you guys have any questions, please let me or Mike know. And best wishes for your exam.